We, as a general dentist, can play a vital role by rehabilitating such patients and improve their functional, aesthetical, and relieve psychological distress. To unveil the treatment modalities, we have amongst us a dynamic speaker and a versatile panelist member. There's a beautiful quote which states, "It does not matter how slowly you go, as long as you do not give up." With this, it's my privilege to introduce our speaker, Dr. Asmath Jehan. Ma'am has completed her BDS from Sri Rajiv Gandhi College of Dental Sciences, Bangalore, and post-graduation in field of prosthodontics from SRM Dental College, Chennai in the year 2021, and has a recent publication. A warm welcome to you, ma'am. And I also take this opportunity to welcome our panelist member, Dr. Shahul Hameed, sir, who has been a dynamic speaker and been a speaker in our webinars. Sir has completed his BDS from Bapuji Dental College and MDS from Vaidehi Dental College and is a certified implantologist from AAID. Sir did his fellow and diplomat from BOCI and formerly worked as an assistant professor in Vaidehi Dental College and currently have a private practice and a consultant implantologist. A warm welcome to you, sir. Over to you, ma'am. Asmath, ma'am, can we start?
Yes. Assalamu alaikum, everyone. Am I audible?
Yes, madam, you're audible.
Okay. Assalamu alaikum, everyone. I'm privileged to be given an opportunity to speak today and share my knowledge with you all. And without wasting much time, let me share my screen with you all. As already told by Dr. Neha, my topic for today is prosthetic management of post-surgical defect in mucormycosis. Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Are you able to see my screen?
Yes, madam, you can see your screen. You can go ahead.
Okay. Okay, firstly, let me give an insight of the maxillofacial defects, what exactly it means. Maxillofacial defects may result as a result of congenital defect like cleft lip, cleft palate, or it can lead due to developmental defect like prognathism, retrognathism, or it may be traumatic due to trauma or surgical resection like post-surgical mucormycosis and the tumor resections. So such defects are huge, and it compromises the appearance and also the function of the patient is affected, especially during speaking, swallowing, and deglutition. So as a result, the psychology and also the social behavior of the patient will reduce. And in order to rehabilitate such patients and to give them a better life, we have to rehabilitate them, and sometimes due to the medical condition of the patient, it will not be easy to give hard and soft tissue augmentation surgeries immediately after resection. And in such scenarios, prosthesis is given, which are called maxillofacial prosthesis. Among the maxillofacial prostheses, the maxillary defects are the most common intraoral defects, and which affects the speaking and swallowing of the patient due to the absence of the palatal floor and due to the defect. And as a result, there is a communication between the oral cavity and the nasopharynx, or the nasal cavity, and the maxillary sinus, and that together becomes a confluent chamber, and during swallowing and food intake, it might go into the nasal cavity, and as a result, nasal discharge will occur, and also the speech also is affected. As I said before, the congenital defects might be cleft lip, cleft palate, and developmental like prognathism, retrognathism, and acquired defects include intraoral, extraoral, or combination of intra and extraoral defects. The maxillary defects are usually sometimes it might be a small defects which does not violate the integrity of the hard palate and the alveolar ridge. Sometimes it might be huge and becomes a confluent chamber with the nasal cavity, and the speech, as I said, speech and deglutition will be affected. So immediately there's a need for a rehabilitation or a prosthesis should be given to improve the quality of life of the patient. So the defect in the palate can be a midline defect, a unilateral defect, a central resection, a bilateral antero-posterior resection, a posterior defect, or an anterior defect. So not going deeper into the classification, the various classifications which has been given, but in order to describe the defect and to know the extent of it, there were 6 criteria were given to describe such defects, which depends upon the dental status of the patient, the oro-antral and the nasal communication status, the structures which are involved, the soft tissue structures or the various structures involved, the superior inferior extent, the antero-posterior extent, and the medial lateral extent. According to the defect, there are various prostheses given, like intraoral prosthesis can be the in the hard palate, it can be obturators, and in the soft palate, it can be meatal or palatal lift prosthesis, and in the mandible, it can be a guide flange prosthesis, or it can be tongue prosthesis. Among the extraoral prosthesis, it can be orbital prosthesis, nasal prosthesis, auricular prosthesis, midfacial prosthesis, and it can be combination like orbitomaxillary or nasomaxillary. As you can see here, among the intraoral prosthesis are the guide flange, the mandibular guide flange prosthesis, the first picture, the second one being the palatal prosthesis, and this is the speech prosthesis. And then among the extraoral prosthesis are the auricular prosthesis, orbital prosthesis, ocular prosthesis, and the nasal prosthesis, or combination of this. So mucormycosis, as you all know, is a black fungal disease which became more prevalent during the second wave of the COVID, and it has high morbidity and mortality rate. And it affected mostly the immunocompromised patients, or the patients with altered metabolic status. And the clinical signs which were seen usually in mucormycosis are headache, sinus congestion, one-side facial swelling, visual disturbances, loss of extraoral function, pupillary fixation, black lesion on nasal and palate, and gingival and periodontal lapses, fever, black pus drainage. The patient comes to the dentist with symptoms like periorbital cellulitis, dental pain, or mucosal sloughing. And some other symptoms include dyspnea, chest pain, nausea, vomiting, gastrointestinal bleeding, coma, can vary with type of and severity of the disease. It might also involve cranial nerves. Some of the clinical forms of mucormycosis are rhinocerebral, pulmonary, gastrointestinal, cutaneous, and disseminated. Rhinocerebral can be rhinoorbital cerebral or rhinomaxillary. Rhinomaxillary is relatively less fatal than rhinoorbital cerebral, but this is the most common which was seen among the mucormycosis. So the infection in rhinocerebral spreads from sinus to the brain, and it is observed in patients with renal transplants or uncontrolled diabetic patients. The lung or pulmonary mucormycosis is usually seen in organ transplant or cancer patients. The gastrointestinal mucormycosis was seen more in children. And the cutaneous was seen due to the outbreak in the skin or in the cutaneous tissue. The disseminated occurs by spreading through the bloodstream. So the disease is diagnosed by the symptoms, history, examination, and laboratory investigation. And also computed tomography scan of the sinus and fungal culture and tissue biopsy. The treatment, the first line of treatment is control of the metabolic disorder, like controlling the diabetes or diabetic ketoacidosis, and then initiation of antifungal therapy. And then finally, you surgically debride the affected tissue. And in case, if required, there is removal of the unilateral or bilateral jaw, or removal of the orbit or eye, depending upon the extent of the disease. After the post-surgical debridement, the defect forms, a defect is formed, which gives a gross facial deformity and facial disfigurement and nasal regurgitation. So to rehabilitate, immediately, you can give obturators for maxillary defects, and for a more permanent solution, you can go for zygomatic implant, or in some cases, pterygoid implants based upon the remaining bone tissue which is present. And also later on, after the healthy tissue is formed, you can go for soft and hard tissue augmentation procedures. So what is an obturator? It is a prosthesis which is primarily given to cover the hard palate and the contiguous alveolar or soft tissue structures, and it restores the oral separation between the oral cavity and the nasal cavity or the sinuses. The objective of it is restoring the aesthetics and protecting the tissue to restore function by separation between the oral and nasal cavities, and to give normal function to the speech, respiration, and deglutition, and also to prevent the contents of the orbit, and also to rehabilitate the psychology of the patient. The obturator, what it does is it serves as a tube for feeding purpose. It forms a base for the packing, and it also boosts the morale of the patient. The types of prostheses are immediate surgical prostheses, temporary prostheses, and permanent obturator. The immediate surgical obturator is a base plate-like device, and it is constructed on the pre-operative impression. What you do is before the resection, you take the impression of the patient, and then make a primary cast, and then you knock down the proposed resection site, and then you construct a prosthesis over that. So advantages of this is it provides the surgical packing, a matrix for the surgical packing. It reduces the contamination of the wound, and it permits deglutition, speech, and help in psychological boost. So this is how you do on the primary cast. The area, the proposed resection area is knocked down, and the base plate is constructed, and to support this is wrought wires are given. In case of teeth, in case of dentulous patient, teeth are taken support of, and in case of edentulous patient, the alveolar ridge, the zygomatic arch, and the anterior nasal spine is used for support. So this is after construction of, after fabrication of this immediate obturator, this is immediately after resection in the surgical room, you give this prosthesis. And after 7 to 10 days, then a delayed surgical obturator is given. And after initial healing and removal of the pack, and a new prosthesis can be given with extension into the defect. An interim prosthesis is given 2 to 3 weeks post-surgical. In this, bulbous extension into the defect is also given. This is given after impression making after 2 to 3 weeks post surgical. So what it does is it maintains patient's comfort, and it maintains palatal junction until definitive prosthesis can be fabricated. The definitive obturator is the permanent obturator, and this is constructed 3 to 4 months post-surgical. So this has proper base plate, and it's having a ridge with teeth, and also bulbous extension into the defect. The impression is taken using a stock impression tray, and the area of the defect, the undercuts are blocked by a gauze which is dipped in petroleum jelly to avoid the impression getting blocked in the undercut, and an alginate impression is taken, and a primary cast is made. This is the primary cast with the defect. So then on the primary cast, the custom tray is fabricated. And then using this custom tray, you take the secondary impression and do the border molding as usual. And also perforations are done for exit of the final impression material. This is the final impression material using silicone impression. And then, as usual, the vertical dimension of occlusion on the secondary cast, you make the occlusal rims, and then you take the vertical dimension and wax rims and take the jaw relation, and then you do the teeth setting, and then wax trial. And then you can fabricate the denture. So this is how the obturator is fabricated. The defect and the final prosthesis. The obturator, the bulbous part, if it is a small defect, then a solid bulb can be made. But in order to reduce the weight of the bulbous part, what we do is hollow the obturator, the bulbous part of the obturator. This is called the hollow bulb obturator, wherein it is fabricated, and what it does is it reduces the weight of the prosthesis. It improves retention, and also the patient is less conscious while wearing. And this hollow obturator seems to reduce the bulbous part, the weight of the bulbous part, from 33% to 6.5%. There's another modification of the obturator in which the bulbous part also is hollow, and also the denture is also kept hollow. So it reduces the weight of the prosthesis further, and also the retention is better. There's another modification in which the antral part of the obturator and the oral part of the obturator is attached by magnet. In case of dentate patients, the usual principles of RPD is followed, like the rigid major connector, the rest, the direct retainer. Not going in detail of the RPD principles. This is a case in which after mucormycosis, a surgical obturator immediately was given, and using wrought wire, the retention was obtained, taking the help of the remaining teeth. And this is the interim prosthesis which was given, and the definitive prosthesis with the metal framework and the in case of combined mid-facial defects, like orbitomaxillary or nasomaxillary prosthesis, where the resection of the nasal cavity, the tumors in the nasal cavity is done. So in such cases, the obturator, the intraoral part, is fabricated first to restore the function, and the extraoral prosthesis is followed. So also after the resection, immediately it is difficult to do further surgeries. As in cases of tumors, the radiation therapy is given prior to the surgical resection. So in such cases, a prosthesis will be better for immediate restoration of the functions. This is combined extraoral and intraoral prosthesis, in which the patient is given a silicone nasal prosthesis, which is attached to the intraoral obturator prosthesis. And the retention used here is the spectacles. Here also magnets, in addition to the spectacles, and the adhesives are used for retention of the extraoral and the intraoral prosthesis. So for the retention of the prosthesis, retention is obtained from the remaining teeth, the alveolar ridge, the residual soft palate, the undercuts, the scar band which is formed, and also magnets, and if possible, for a permanent solution, implants are given. Now, implant retained prosthesis for the maxillary defects are better retentive, and also since it is not removable appliance, so it will be better for mastication, speech, and swallowing. And the implant sites depend upon the extent of the defect and the remaining bone which is present. The preferred bone is the premaxillary segment. If that is not present, then the maxillary tuberosity is used. And following implant placement, 6 to 8 months after the surgical resection, this implants can be given. And also for further improvement, palatal grafts can be given. And implants can be given in pterygoid bone or in the zygomatic bone. The complications for implant supported is fewer sites are available after the resection, and the occlusal forces are also in the have multiple axes of rotation. This is a case where after mucormycosis, the defect, zygomatic and pterygoid implants were given, and also bicortical implants in the premaxilla were given, and the prosthesis framework was given, and the obturator was given. Also, in the recent advances, like the scan, the intraoral, by the introduction of these newer intraoral scans, you can take an intraoral scan or the scan of the cast and the face scan, and then you merge this with the CBCT data, and then you can do a CAD/CAM fabrication of the obturator. Since CAD/CAM obturators can't be hollowed, so rapid prototyping or selective laser sintering is done to hollow the obturator. This is the additive and this is how the final obturator is given. Thank you.
Thank you, ma'am, for such an innovative presentation. I request Shahul Hameed, sir, if you can add up some points to the ma'am's presentation. Would you like to add some points, sir?
Well, I actually am no one to add any points, but then a fantastic presentation, Dr. Asmath, ma'am. And can you hear me?
Yes, sir, we can hear you.
Yeah. Just a couple of points that the mucormycosis has today become an important topic for us. Previously, it wasn't, because it is an opportunistic infection. But most of this presentation, or most of it, basically depends on what do you say, that it is correlative even to rehabilitation of prosthetic rehabilitation post tumor dissection also. It's the same way, same principles that we follow.
What is this?
Hello.
Upsarg.
Hello.
Sanskrit ke upsarg. Or in upsarg, we have only Sanskrit ke upsarg.
Hello.
Yes, sir. Sorry for the disturbance.
Okay, yeah. When you talk about the prosthetic rehabilitation, it completely it will be after the tumor resection. We call it a tumor resection, whereas after the infective tissue has been resected. Most important things we have to take into consideration is what is the first of all interim prosthesis and immediate surgical obturators and interim prosthesis is not much given in such treatments. In these cases of tumor, in cases of mucormycosis, most of them we are looking at definitive obturators and definitive prosthetic planning.
Those are basically
hello.
And suffix is pretty. So you don't have suffix.
I
No.
request
Hi,
Arsha ma'am to please mute yourself, ma'am, if you can, please.
someone in the background who's communicating. Yeah, that's what. So yes, we are looking at mostly definitive obturators and definitive prosthetic planning, which we need to do for such patients because they usually are referred to the to us probably 2 or 3 months post this a phase of mucormycosis followed by surgical resection of the infective areas. So yes, every obturator or every type of a prosthesis which is to begin surgical, interim, definitive, they all have some timings. And definitive process, what we always plan, and it should be always given after 3 to 4 months. And most important is while we define that particularly, there are certain factors we take into consideration. Would be the number of remaining teeth present, the extent of the defect, most importantly, the state of the healing, the dimensions of the defect are also taken into consideration. Because there are dimensional changes which will be occurring due to structuring of the wound and the scar contracture, which will definitely which will happen till at least 1 year, and they are definitely related to the overall success of our prosthesis. And more importantly, because mucormycosis as a fungal infection can recur, it has a very aggressive, it's very aggressive and can recur. So we should not jump into doing the process immediately. Wait for a periodic follow-up by the surgeon and make sure that the system is completely clear, and then look forward for processes. And when you're talking about processes, today we are in the world of implants, of course. So whatever Madam spoke about are removable prostheses. Of course, we can also look forward for giving fixed prosthetic rehabilitation using dental implants, that is in the zygomatic and pterygoid implants. And till now that we are already reached into the level of 3D computer-aided designing and manufacturing CAD/CAM technology for redeveloping the framework of the maxillary bone and using that to rehabilitate the patients and be able to give them fixed teeth. And so 2 important things when we are trying to do a prosthetic rehab: we are trying to close the defect, that is oronasal defect. And second is we are trying to make sure that the patient is rehabilitated with the teeth so that he can go back to normal form and function. So having said that, let's we can start up with the question hour session. Dr. Neha, Dr. Asmath ma'am.
Yes, sir. I have few queries, sir. What would be the what would be the differential diagnosis for mucormycosis? If a patient is coming to a clinic, definitely there should be the diagnosis. Can you please elaborate? Hello.
I think Dr. Asmath did not hear the question. Can you repeat the question, Dr. Neha? Dr. Asmath, the question is directed towards you.
Ma'am, what would be the differential diagnosis, ma'am, for mucormycosis?
Like other opportunistic infections, I think Dr. Nair can. I'm waiting for Dr. Nair to speak on this topic. Is this all his topic?
Actually, when we talk about, well, sorry to interrupt. When we talk about differential diagnosis, when we talk about infection as a differential diagnosis, then we'll have candidal infections and aspergillosis to be reported as a principal pathogen, which is again of fungal origin as a co-infection for patients with this COVID-19. But as such, if you look at the way it is very closely related to tumors, so aggressive, it also shows like an aggressive tumor to patients, but very typical way of, it shows up in specifically COVID patients who are highly immunocompromised and patients who are having uncontrolled diabetes. So it's easy to locate, it's easy to diagnose that, yes, this is a case of mucormycosis, of course, with some diagnostic tools, which we try to see and check what it is. Not much, but differential diagnosis can be just tumors, aggressive somatognatic system tumors like OMS, oral submucous fibrosing, what do you call that? I'm forgetting that.
Carcinomas.
Carcinomas, yeah. Oral carcinomas and candidiasis and aspergillosis, yes.
So as you said, this is seen mostly in immunocompromised. We as normal general dentist or as a student, we always have this doubt. Okay, we are learning mucormycosis seen in diabetics. Why it is seen in only in immunocompromised?
Now, the thing with fungal infections, this type of fungal infection, it is a complete. If you actually go back into the pathology of this particular mucormycosis or the mucor fungus, it's a very commonly seen fungus in our soil and in our environment. It will actually not cause any type of issues to us because of a very strong immune system. But patients where the immune system is highly compromised, these fungal spores are absorbed by the nasal cavity, and they go and attack the blood vessels. They form thrombosis, and then they start causing necrosis of the soft tissues. So that's where is the common site. You're seeing them in the paranasal sinuses and the nasal area. That's the preorbital area where you see that, where it is picked up, where it gets picked up into the body and starts causing the infection. So on normal system, it should be removed from the system because of our immune system is strong enough to remove it. But because of COVID-19, what has happened is patients are on a high amount of corticosteroids and immunosuppressants, which will which will reduce the body's immunity, thereby all types of opportunity. So it can also occur with patients who are HIV and full-blown HIV patients also are susceptible to this mucormycosis, any type of opportunistic infections.
Just to add on, actually, regarding the differential diagnosis of mucormycosis. The thing is, as we all know, that the mucormycosis is actually an highly invasive fungal disease. And then it's actually occurred, it's mostly should be considered in any immunocompromised patient presenting with any sort of swelling and other inflammation in terms of the orbital complex or the nasal complex or the dentollar complex. But in terms of the differential diagnosis per se, we can actually differentiate them in terms of facial swelling, similar to orbital cellulitis, and there's also extranodal T-cell lymphoma or even cutaneous anthrax. They present with a similar presentation as that of oral mucormycosis. But then the most important aspect is the histological identification of this lesion. And sometimes if it's associated with ulceration and destruction, and then these kind of lesions where of course it needs extensive evaluations and surgical curettage and debridement followed by prosthetic rehabilitation. And I have a small query regarding this thing, interim prosthesis. So, I mean, when we're talking about this question is to any of the three people, I think, okay, it's an open question. And depending on the phase of the treatment, the prosthetic rehabilitation for the acquired palatal defects, it can be immediate surgical obturator or transitional or the definitive obturator. Now, the fabrication of these obturators, is it similar to everything? I mean, one and all, or what exactly is different in these three obturators? No. When we say there is an immediate surgical obturator, and when we say the transitional obturator, and the final one is a definitive obturator, what exactly is differentiates each?
Like the surgical obturator is constructed on the cast which is made from the impression before the removal of the surgical debris. Like before doing any surgery, you take the impression of the patient, and then on the primary cast, then you knock down all the proposed site of resection, and then you make an obturator. It is not that well fitting, but then you can always use soft liners to modify it later on. But initially, just to give a surgical packing, you give. And this surgical obturator is given in the surgical room. And all other are made on the post-surgical impression. That is the main difference. And then after the healing when you can take the impression of the patient, then you do the interim and the definitive process.
So a point to add it is that, surgical obturators are basically, they are vague they are vague processes. They are like, they are not specifically perfectly designed, and the outline of the margins are not really specific. They are arbitrarily made, and they are modified on the operating table according to the operating surgeon. Well, there's a discussion done before the surgery. According to that, it's marked on the model and then done it. But then if you open up and the surgeon wants to do a little extra resection or wants to limit the resection, then the process is modified. And the surgical obturator or the surgical prosthesis is given not more than 6 days for post-surgery. After 6 days of the placement at the time of surgery, it is placed, and 6 days later it is removed, and a little, a delayed surgical obturator is fabricated with the help of these tissue conditioners that are slightly modified. After which we will move, because we need around 5 to 6 months before we go over the definitive obturator. So between that, the surgical and the interim is being done. So,
but how appropriate is it to term it as a surgical obturator rather than just calling it a surgical stent?
So surgical stent would be, it is basically the word stent itself means like it is going to be helping the surgeon to resect a particular thing, or it will add into or help the surgeon to do the particular job, like demarcate the areas and help him resecting the system. The obturator or the surgical processes is done immediately on the table after the after the surgeon has gone ahead and resected. It will not have anything with what the surgeon is trying to resect and what the process is made. They're not actually completely correlated to each other.
Okay.
Because stent means, it's like how we have implant stents. It is helping you in a direction to help the surgeon to resect. Here, it is not that. It's just that when the surgeon finishes the procedure of resecting, we need to close the defect. So most of the times, if the surgeon is able to use hard and soft tissue grafts to do that, fine. If the surgeon and the prosthetist have decided that, they cannot do a reconstruction using soft and hard tissues, then this type of a prosthetic system is given in order to close those defects temporarily.
Okay.
Asmath ma'am, there's a question by Arshia ma'am. The post-surgical soft tissues are scarred and tense, which exerts strong dislodging forces. So how will you modify the obturator to keep it in place?
Actually, the scar tissue is used as a retention aid for the prosthesis, and mainly what is checked before giving a prosthesis is the keratinized mucosa. So when there is keratinized mucosa, then the retention will be better. So that is why it is the definitive prosthesis is delayed after a healthy keratinized mucosa is formed.
Okay, ma'am, I have a query. Is there any significant pathology of the teeth that initiates the prognosis of mucormycosis? Because in certain cases, if there is no involvement of teeth, we generally tend to keep those teeth for retention. And if those teeth are having deep dental caries or anything like that, so first, we tend to keep that in the mouth, like we don't advise extraction. That we may require endodontic treatment. So this treatment that are like endodontic treatment and all, will it be given after we give an obturator or prior giving an obturator?
I don't think you can do any these procedures for a patient who is already immunocompromised, and for such patients, the main objective is to first get rid of the infection, which is more invasive and more it is having more mortality rate than a normal extraction or root canal treatment.
Actually, I agree with ma'am. Actually, well said, madam. At the time when the patient has been diagnosed with mucormycosis, the least of his concern is a root canal to be done or something. He's looking at a life-threatening concept where it's just a matter of days before his eye is involved. It's just a matter of days, and it goes into the base of the skull, and further the system deteriorates. So when we are looking at the treatment of the surgical debridement and things, that always takes a precedence as an emergency line of treatment. And when we are looking at, as Dr. Neha said, what are at the time of doing the definitive prosthesis, yes, we are absolutely right. We have to make sure that our retained teeth are absolutely healthy, both periodontally as well as endodontically. They are completely healthy. They have to be properly re-restored, make sure that everything is fine, probably crowned or root canal treated, crowned, and in fact, it also helps us when we are doing our cast partial dentures. In fact, I had a case where the patient came to me after the particular procedure, and we had to do root canals for 3 teeth and use that as it helped us when we were doing a definitive cast partial dentures by making it like an over denture concept for the patient and giving it. So we have to retain as many good teeth as possible and treat them properly, make sure, because they are going to be the extra anchorage of support for us for make sure the prosthesis success.
There's one more query. What is the difference between static and functional obturators?
Functional obturators are basic. Ma'am, can you say? Okay,
if you can please take up this question.
See, functional obturators is nothing, it's just another name. Functional obturator means something which is a definitive obturator used for both aesthetics and functionality. Static obturators are just like simple surgical plate given as a surgical obturator where you're not adding any functionality to it. It's just acting like a cover to close the oroantral defect. That's it.
To add up to this, actually, the actual difference between static and functional obturator is any obturator that covers the defect in the area of the palate, starting from the lips to the junction of the hard palate. And basically, in this kind of obturators, the static obturator, the soft palate is not really covered. Okay, it's only on the anterior region from the soft palate. But whereas the functional obturator, this provides a definitive closure in the soft palate in the pharyngeal areas, actually, and also that provides surface contact which is against the movable tissue functions, as in the soft palate or in even the nasopharyngeal region. Okay, the entire idea is it's actually difficult to fabricate a functional obturator compared to the static obturator. But when you're talking about the intraoral aspect itself, the static obturator is only the obturator which is fabricated only to cover the alveolar ridges, the hard palate, and the lip. But the functional aspect comes to the functional aspect of the tissues which are moving, including the soft palate and the muscles.
Ma'am, I have a query. Is there any precautions that to be taken during impression making? When we make an impression, are there any particular precautions to be taken?
Yes, during before the impression, you cover the defect with a gauze, so that the contents inside the nasal cavity, inside the defect, whatever supporting structures are there, that is safe, and so that the impression material doesn't go inside after that you put a alginate material to take the impression.
Ma'am, just a doubt. In extracoronal retentions, we have implants, we have magnets, and then you had spoken about the SCAT-CAM, the recent advances. So if you have to classify them or grade them according to the retention, which would have a better retention, ma'am?
No, CAD/CAM is totally it's related with the fabrication of the
Yes,
obturators.
fabrication. Fabrication.
The retention is always, implant is better than others, but since there's less bone left and there's less choice of implant sites after the defect. In case of larger defect, then you don't have many options, and also the medical condition of the patient and how well patient can go further surgeries also counts. So otherwise implants is best, but then you should always go for these the RPD and the this thing which are having newer retentive features like the attachments and the magnets are old, but then you give this resilient attachments and other things are also come up. And if the patient is medically capable of undergoing implant surgery, then implant supported prosthesis is always better.
Okay, ma'am. So the CAD/CAM fabricated prosthesis and conventional prosthesis, which would you prefer, ma'am?
No, CAD/CAM is always better since it is better retentive, but then in CAD/CAM the hollowing is not possible. In a conventional, hollowing is possible, but even newer advances like the selective laser sintering, the additive manufacturing, the the 3D printing, this using this you can even make hollow bulb obturators as well.
The whole idea behind deciding the final prosthesis depends on a lot of factors like the anatomical undercuts which are present, favorable anatomical undercuts rather I should say, which are present, and the type of prosthesis design we want to do. We also need to take into consideration the weight of the prosthesis. So at the end of this, here we are looking at a highly compromised retentive area. Where we're not getting extra retention from us. The only retention we are getting it from a couple of teeth left over, and the defect per se, some undercuts in the anatomical undercuts in the defect. So we need to be very careful when we're deciding the nature of the prosthesis, whether it is a cast partial, that is a metal framework based prosthesis, whether it's an acrylic prosthesis. I'm talking about removable ones to be specific. We need to make, ma'am mentioned about hollow prosthesis. It's basically hollow obturators, basically given with an intention to decrease the weight of the prosthesis, because the lighter the prosthesis, the better it is retentive and is able to hold in its particular place. So taking that into consideration, of course, CAD/CAM is a methodology in fabricating the prosthesis, the framework, but the word CAD/CAM itself would mean that it is quite, and selective laser sintering would mean that it's a precise work done as compared to doing an arbitrary lost wax technique for the cast fabrication. So yes, CAD/CAM would always be better. But when you talk about removable prosthesis, where there are some teeth which are left over, that is, it is partially edentulous, cast partials are the best in terms of removal. But if you do not have teeth, and the hollow obturators are the best, or two-part prostheses are the best. When you talk about fixed rehabilitation using zygomatic implants, pterygoid implants, or framework-based implants, they are the best.
Okay, sir. Asmath ma'am, there's one more query. Do these obturator affect the speech?
Actually, due to the defect, the speech is affected, and there is a nasal tone in the speech while speaking. The patient has nasal tone due to the defect. So, to improve the speech, this obturator is given, and also some obturators have extension which will help in speech further, like speech prosthesis. So obturator actually improves the speech.
One more doubt. Ma'am, this when we are making an impression, if it's a minor defect, is secondary impression required in such cases? Or we can just, because when we are making a primary impression, and if the undercut that is required for retention purpose, if it's recorded in primary cast, is it required that we do secondary impression in such cases?
Secondary impression is mainly to record the sulcus depth and the all the finer undercuts, which is always better. You will not get the extent of the sulcus and because the flanges always helps in the retention of the prosthesis. So only in the secondary impression you can get the
if it's only the anterior, say only anterior 2 teeth or 3, not generally, not only in mucormycosis patients, general patients, if we have done osteomyelitis cases and all, only if anterior teeth have been resected, only that part. In such cases also, should we have to perform a secondary impression?
Absolutely, it is.
I think secondary impression is a must as a without that a primary impression will not record the finer details, and also the retention especially will be compromised with the primary impression.
Thank you, ma'am.
Primary impressions are just diagnostic models to give us an idea of what we are not able to see in the mouth we are seeing on the model. As ma'am said, recording the sulcuses, the correct exact depth and the exact borders is very important for the overall retention and stability of the denture. And secondary impressions with border molding and using putty light body, that is basically a silicone material to record the finer details, is absolutely required, whatever the case may be, whether it is a simple case where you're doing hard tissue recording, or whether it is even a complete denture. So secondary impression is important because that is the master model on which you have to fabricate your processes. You can't fabricate processes on diagnostic models. Absolutely not.
Thank you, sir. Ma'am, there's one more query. How do we plan the occlusion in patients with hemi maxillectomy or total maxillectomy obturators?
Usually if possible, after taking the jaw relation, everything, if possible, even the face bow record is also taken. And also the teeth which is given is non-anatomic teeth, so that first the patient should adapt to the prosthesis. That is the main idea. And then the occlusion is which is possible at that particular especially in total maxillectomy cases. In hemi maxillectomy, if the extent is very small, then all the procedures which are followed in the jaw relation is done to get a proper occlusion.
So to add a point here to ma'am's thing, when you're looking at occlusion as a point, we are first of all not looking at giving a mutually protected occlusion. Absolutely not. We are not giving any type of mutually protected occlusion or trying to give a cusp-to-cusp proper occlusion. We are, as ma'am said, we are looking at semi-anatomic teeth or non-anatomic teeth, that is flat teeth, to give a type of a concept of a balanced type of occlusion, where even if the patient is trying to do an anterior guidance or a posterior, it's always going to be in contact. And the occlusion is not mutually protected. It is more of a concept of a balanced way of giving the teeth, because we are looking at fixed teeth in the lower jaw and removable teeth in the upper. So yes, semi-anatomic or non-anatomic teeth, we are reducing the occlusal table size, and we are trying to give a chewability to the patient, where we are looking at giving a non-mutual protected occlusion, or you can say a balanced occlusion for it. But when you're talking about fixed implants, like you're trying to rehabilitate using implants, Then we are giving implant protected occlusion over there and looking at the extent of the teeth which we are trying to replace, whether it's the anterior or the posterior. Consequently, that type of occlusion has been a group function or mutually protected can be given, because that time we are looking at fixed teeth as an option, not removal.
Ma'am, there's a query. If there is a surgical defect causing undercut areas which cannot be seen, how do we manage the impression while removing it?
Sorry, can you repeat the question?
The question is basically if the surgical defect which is causing the undercut areas cannot be seen, that is it is vertically present in the oronatal area, probably that's what sir is mentioning. How do we manage the impression while removing it? Would that material get dislodged or would it be intact? How are we able to retrieve the impression without disturbing the overall thing?
Okay, actually, if there is any deep undercuts, you block the undercut and then with a gauze or something, and then you take the impression of the defect. Otherwise, the material might get stuck in the undercut. So basically, you block some of the undercuts which are very deep and which might not possibly will be a problem during impression making.
Now, from a surgeon's point of view, I think we would make it a point to see to it that the margins are self-cleansing. I think we wouldn't, I wouldn't recommend anybody to actually resect an area and then keep a sharp edge or a sharp point or a ledge, which would
Actually, sir, first during impression making, you block the undercut, and while fabricating the prosthesis, you use this undercut for retention.
And one more point is that at the end of the day, these obturators are like the vertical extensions into the oronasal chamber. So, but our whole objective is not to record the entire oronasal chamber. Our objective is to just record the superficial areas of the because we're trying to close the natural border which was there, the maxillary bone which is separating the oral and orbital cavities. That area we are just trying to record. We are not trying to record the entire oronator, because if we are trying to make an obturator a highly long vertical obturator, then we cannot insert it and remove it easily. So we are just recording only the superficial part of that particular defect region, just as basic undercut region. I think 1 or 3-4 millimeters above the defect. We are not trying to here record the entire nasal chamber.
I think the literal meaning of obturator is top up.
Yes.
And also, sir, it's because that is why we take the secondary impression, so that it will record the whatever is left during the primary impression.
But when we are actually taking the impression, like Dr. Shahul very rightly pointed out, I think we are not taking the entire impression of the entire, anatomic.
No, we are not trying to take that.
We are just taking the, I think, 4 mm or 5 mm superficial to
just the borders of it.
Yeah, what the missing part is. For example, if the palate is missing, we are only recording 4 mm or 5 mm above the hard palate or whatever it is.
But if a patient is coming up with a major panfacial defect where you're looking at extraoral, also you have a nasal defect, intraoral you have a maxillary bone defect and all, then we are trying to giving 2-piece processes. We are looking at giving an obturator separately, which is only again engaging that way, and then we are giving us extraoral processes, which is covering the nasal part. We are not trying to combine both of them and give it, because then with insertion.
But then if you're giving extraoral processes, it's not called as an obturator, isn't it?
It will be completely a different thing. It is an extraoral processes, silicon based, giving trying to
it's actually maxillofacial processes.
Maxillofacial process, the word should be perfect. Yes.
Actually, impression making for extraoral prosthesis is completely different. You take a facial moulage. This intraoral prosthesis is the normal impressions what we take. So, and also the material used there you in the intraoral you need some hard material, and for the extraoral you need some soft material. So you can only join both parts. You can't make with the same material, and impression also is different for extraoral and intraoral.
One point I wanted to ask Neha, sir, I wanted to add into the discussion over here is, now out of like around 6 or 7 cases which came to me post-COVID for mucormycosis for rehabilitation, I've seen cases during my postgraduate time with tumor resection where we have definitive open up chambers. That is the communication between the oronasal chamber is open and we are trying to rehabilitate. But out of all the 6 cases which I got, unfortunately, I got all the cases where the entire palate was covered. Like it was completely covered, completely healed with a small opening in the sulcus area, a little bit of non-closure over there. Which makes it a little more difficult for us to rehabilitate because behind the soft tissue, there is nothing. The soft tissue has nicely covered up the defect, now giving us no anatomical undercuts to really rehabilitate. From the surgical point of view, what is your take on that, sir? Because at the end of the day, you're trying to
concept of fabrication of obturators is actually, it is just to another alternative option of preventing a secondary reconstructive surgery. You know, in terms of economic, socioeconomic status of a patient, if they cannot afford the secondary reconstructive surgery, they can opt for a cheaper version of the prosthetic rehabilitation, such as the obturator. But then if they can afford it, they can always be soft tissue reconstructions or hard tissue reconstructions, depending on the size of the defect. But when you say there is a definitive differentiation in terms of the surgical procedure when it comes to tumor resections or the fungal resections. Basically, see, mucormycosis is a fungal infection, and then you don't extensively debride it and then curate it compared to the tumor. The thing with tumor resections is there is microinvasions, and then to do this, majority of the surgeons prefer extensive or radical excisions, and around they expect of a minimum of 1 centimeter margins around, or I think go up to above 6 millimeters margins. Even if it is normal region, normal area surrounding the tumor, they expect it to be excised just to be on the safer side. But as the technological advancements and then the radiological advancements, they are more specific, and then they're trying to be more functional, and then they're going to be more conservative. But when it comes to fungus, the main objective is debridement. Okay, but in comparison to the tumor and the other excisions, it is not debridement. It is proper excision. Okay, now for example, you have a fungal infection which is localized. It's not advisable to go in for a radical excision of that particular region, having a 7 millimeter wide margins or 10 centimeter wide margins. But when it comes to tumor, you have to excise. Even if it is, for example, if you have ameloblastoma of the ramus of the mandible, okay, the ideal treatment right now is not, I think, hemimandibulectomy. Okay, nobody would say you just do segmental resection or dental resection and then just curate out the tumor and then reconstruct it. The microscopic infiltration, it makes a lot of difference. But when it comes to fungal infection, it's always localized.
So we should consider mucormycosis as, just basic surgical debridement. It will not be called as resection.
That is the entire understanding, and then that's the entire objective of it. Okay. See, the entire palate is involved. You debride it, and then you see it, and then whatever you just curate it, and then you smoothen the regions.
Now the problem for us as prosthodontists is that behind the palate, now it is soft. It is no more a hard.
It's a physiologic space. The anal cavity or the nasal cavity.
So when we are preparing our prosthesis has to go and settle on that particular soft tissue. So now it's movable in nature. It is not hard. So we can't exert pressure on it.
This is when the question about static and functional obturators come into place. Okay, if you have too much of musculature or movement and the muscles or in the soft tissues, that's when you fabricate a functional obturator. If it's a static structure such as hard palate or the alveolar dentoalveolar complex or anterior lip, you go in for static obturators. But then again, it all depends on the impression technique and impression for fabrication of the prosthesis, wherein you're not pushing the entire impression material above and beyond what is actually needed. I mean, if you want to record the entire antral cavity, what is the objective of taking the entire antral cavity when the defect is only in the soft palate with a small hole?
Okay.
I think this is another question.
Ma'am, thank you, sir. Ma'am, there's one more query. Can we use sodium carboxymethyl cellulose as an add-on for the retention if the obturator is loose?
Okay.
Dr. Shahul, can you take up that question? I have no idea.
Basically, I'm saying, can we use these, denture fix-on material, or you can say retentive, retention-based materials for doing that? Sodium carboxymethyl cellulose is nothing but fix-on. Retention of the obturator, if the obturator is used, is what we use is tissue conditioners. We don't want to use any type of such material because actually not going to help in retention. What is the use of the sodium carboxymethyl cellulose? It's basically forming a bond between, or you can say like a sticking agent between the soft tissue and the surface of the soft tissue and the surface of the denture surface. Okay, integral surface of the denture. Here you're looking at an obturator. So obturators really cannot work with, the retention is not going to be helped with the help. It will not add up to the retention. For that you need consequently every month or 2 months of using of tissue conditioners, periodic use of tissue conditioners for that to add on to the retention of the obturator.
I think we are done with the queries. Anyone have any queries? Naya sir, is any queries?
No, it was really a very overwhelming discussion and very elaborate presentation on mucormycosis and its prosthetic rehabilitation. I would really thank Dr. Asmath and well moderated by Dr. Neha and also well paneled by Dr. Shahul Hameed. I think from my side, I think that's about the questions. If there are questions from other people, I think we can wait for another few minutes and then you can call it there.
Okay, sir. I think as a general dentist, we always hesitate if such patients come. But I'm sure, ma'am, after your presentation, if right now I'm doing my PG, so we be seeing the cases. But as a general dentist, if I whatever the first thought was like, where is my senior doctor? But after your presentation, I'm sure there are many like students like me in the group who may be attending. So they would have definitely got a confidence like, okay, we can attend it. So it's very informative. Thank you so much, Asmath ma'am and Shahul sir, for sharing such a knowledgeable and immense knowledge based presentation it was. Anybody has queries? Can directly unmute yourself. So can I wind up the session, please?
Yes, Dr. Neha.
Gratitude is the inward feeling of kindness received, and thankfulness is the natural impulse to express that feeling. Feeling gratitude and thankful to Team GDP for giving me this opportunity to be part of today's webinar. I thank Dr. Asmath and Dr. Shahul for sharing their immense knowledge. Listening is the art that requires attention over talent, others over self. I thank all the members who attended today's webinar. Thank you so much. Thank you, everyone.